Everyone, thank you for joining PHCA's webinar titled Better Serving the Lesbian, Gay, Bisexual, and Transgender Populations in a Healthcare Setting. My name is Abby Foster. I am the Director of Marketing and Member Services for the Pennsylvania Healthcare Association. PHCA offers monthly webinars to members for NAB-approved credits in order to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and gain a better understanding of practical application tools to equip our members so they can continue to provide the highest level of quality care possible. In acknowledgement of LGBT Pride Month and with the importance of this focus spanning across the healthcare industry, PHCA was happy to make this educational offering available to members and non-members. The objectives of today's webinars are to understand the needs of the LGBT community, respect each person's uniqueness as part of our commitment to deliver person-centered care, and enhance our ability to effectively listen, respond, and provide care to all residents or patients, regardless of personal feelings, beliefs, or values. Before I introduce our speakers, I have a few housekeeping items to cover. This webinar will be recorded and made available on the PHCA website following the live presentation. The webinar has been approved for 2 continuing education credits for nursing home administrators, both skilled and assisted living personal care, and 2 continuing education credits for nursing. Certificates will be emailed following the conclusion of the presentation. If you need a nursing certificate as well as an NHA or just the nursing certificate, please reply to the email with your request and I will send. Several of you are participating in a group setting. We think that's wonderful. We ask that you register the names of all attendees for our credit issuance record keeping so that at some point during the presentation or reply to the credit email that I send following the live presentation. All attendees will be in listen-only mode, but throughout the presentation, please feel free to submit questions via your questions pane, and our presenters will address them at the end of the presentation. I'm now thrilled to introduce our presenters. Sarah Newman Boateng is the Special Assistant to Dr. Rachel Levine, Pennsylvania's Physician General. Dr. Levine was called away for a brief meeting this afternoon, but hopes to join us later for the question and answer portion. Sarah is the Special Assistant to Dr. Levine. In her current role, she works on the Department of Health's response to the prescription opioid and heroin crisis, the management of the Bureaus of Epidemiology and Laboratories, and LGBT health disparities. Prior to joining the Pennsylvania Department of Health, Sarah worked for U.S. Senator Bob Casey on health policy and served as his statewide LGBT affairs advisor. Additionally, she has served as the Director of Public Affairs for Planned Parenthood Keystone. On behalf of the American Healthcare Association and National Center for Assisted Living, we have Dr. Lindsay Schwartz. Lindsay earned her Ph.D. from the Johns Hopkins University Bloomberg School of Public Health in the Department of Health Policy and Management and currently serves as the Senior Director of Workforce and Quality Improvement at AHCA NCAL. Our speakers are clearly qualified to present on this topic, and we are looking forward to excellent insight, education, and dialogue. I'm now going to turn the presentation over to Sarah from Dr. Levine's office for a quick introduction.
Good afternoon. I'm so pleased to join you this afternoon and welcome you all to this very important presentation. As many of you know, it has been a priority of Dr. Levine as a member of Governor Wolf's administration to bring attention and awareness to the LGBT community and their health needs. This presentation is incredibly timely and needed. The recent estimates suggest that there are 1.5 million LGBT people 65 and older in the U.S. This number will double by the year 2030. Many LGBT older adults, because of a lifetime of stigma, deal with poverty and reduced economic security. Additionally, LGBT older adults are at a particular risk for social isolation. Many have lost touch with close family members or children and are at particular risk for being unconnected to the community. This presentation, and I look forward to the remarks from Dr. Schwartz, and she'll dive into these topics, but I wanted to highlight a few suggestions that Dr. Levine often shares when talking with healthcare providers. It's important to remember that words matter. I'm glad that this presentation takes time to explain terminology and helps participants learn a bit about the words that the LGBT community uses when talking about themselves. A good tip is don't make assumptions. When you meet new people, Don't assume their gender identity based on looks, their sexual orientation, based on presentation. When you don't know, simply ask. I want to thank the Healthcare Association for this presentation, and Dr. Levine looks forward to joining you during the question and answer portion of this event. Thank you.
We'll now hand the presentation over to Dr. Lindsay Schwartz, the American Healthcare Association National Center for Assisted Living.
Great. Thank you, Sarah and Abby. Hi, everyone. I'm glad you were able to join us and look forward to a good presentation and some great discussion afterwards. So I first want to go through learning objectives and talk about what we're going to be going over today. So we're really going to be discussing the needs of the LGBT community. As Sarah said, we're going to go over terminology. I couldn't have said it better. Words really do matter. We're also going to talk about respecting each other's uniqueness as part of our commitment to deliver person-centered care. We talk about person-centered care so much in assisted living, but really person-centered care is vitally important across healthcare, and I really think we've seen a push towards that in at least the last decade, and talking about really taking individuals holistically, thinking about psychosocial aspects, not just our physical health, and how important that is to the care we receive. We're also just going to talk about our ability to enhance listening, responding, and providing care to everyone, regardless of personal feelings, beliefs, and values. So I mentioned we're going to talk about terminology. And LGBT, I'm sure many of you know this, but just to go over this, stands for lesbian, gay, bisexual, and transgender. So I do want to just note and point out, a lot of times you'll see LGBTQ, and the Q stands for queer. We at HCA and Cal have had a discussion, and we tend to try to look at this every year, and have decided just to leave that out. You'll see it sometimes, and other times you won't. We serve older adults and felt that that term just isn't used as commonly with older adults. You hear that a lot of times with younger adults in many ways, that other terminology that we've heard, whether it be regarding race or ethnicity, that we've taken terms that were offensive at one point and started to use them to really take those back and take that offensiveness away out of that term. Again, we just choose not to use that word at HCA and Cal at this time. Maybe that will change in the future as baby boomers age, and we use that term. But words matter, and I will say this many times. It's important that the individual you serve, you understand the terminology that they use and just use that terminology. So if they use the term queer and they're okay with that, then you should use that term if you're comfortable and the individual you're serving with does. Next, I want to talk about sex. Sex is determined by biological chromosomes, hormones, and anatomy. Really, and there's a big difference between gender identity and sex. So gender identity is a person's internal sense of being a woman or a boy or a man or a girl. And gender expression is the physical manifestation of gender identity, usually expressed through clothing, mannerisms, and chosen names. And I just want to point out something very small, that sex, the difference between a boy and a girl is very small, and we're going to talk about intersex later on, and I'll get into that more. So heterosexual and homosexual. Heterosexual are people who are romantically attracted to someone of the other gender, while homosexual are people who are romantically attracted to people of the same gender. You don't hear the word homosexual a lot anymore. LGBT is really that accepted term. You hear it a lot more in medical terminology, but we've really moved away from that terminology. Not that there's anything offensive with it, we've just changed more towards using LGBT than homosexual. So a gay man, or men who are romantically and are sexually attractive, active with men, I can't stress this enough. Gay should be used as a description and not as a noun. I hate to say it, but I still see this and I still hear this. And I quickly, very quickly, correct people when I hear this. If you are working with staff that are utilizing this as a noun, you need to shut that down quickly. It's offensive. It is not a noun. It should never be used as a noun. And it's important we teach our staff this. We also work with residents. I realize this can be difficult, especially when we're working with residents that may have dementia. So filters can be hindered, but it's really important that utilizing this as a noun is never acceptable, and that is shared with your staff and with residents or whomever is in your healthcare setting that you're working with. Lesbians are women who are romantically and are sexually attractive, active with women. Bisexual individuals are people who are attracted to and are sexually active with people of both genders. So what can be a little confusing sometimes, and I just want to point out that on bisexuality, bisexual behavior and bisexual identity can be two different things. So an example would be a woman may be married for many years and had children with a man, and then comes out later in life as a lesbian, and then is sexually active with women but not men. That woman may identify herself as a lesbian rather than bisexual. Again, I said it before, and I'll say it, I'm sure, again in this presentation. It's just important to understand what an individual prefers and what their identity is, and to go with that. If that's how she identifies herself, that is how she identifies herself. And it's important in regarding person-centered care that we use adjectives and terminology that someone is comfortable with and self-identifies with. It's not how we perceive them. Same-sex partners just refer to same-sex couples in committed relationships, including marriage. We're going to talk about marriage equality later on, civil unions or similar relationships that may not be recognized under law, but again, a lot of that has really changed. I want to talk also about transgender and intersex, as I mentioned before. So transgender is independent of sexual orientation and describes those whose gender identity and or gender expression do not match the stereotypes associated with the gender that was assigned to them at birth. They often live as a member of the opposite sex. So transgender is truly an umbrella term. It encompasses transsexuals, which I'll talk about in the next slide, drag artists, cross-dressers, and it's really important to understand, again, and use the terminology that someone prefers. I also want to touch on intersex. So that is when someone has ambiguous genitalia. Now, about 1% of live births are intersex. That is older data, so that might be updated. I will put that out there. The old term that was used was hermaphrodite. We do not use that term anymore. Intersex is a term that is politically correct and that we use today. It's also really important, as I mentioned before, that the biological distance between being a male or female is not as great as we may think. Going back to your biology days, if you took biology, or obviously if you're a healthcare worker, you probably remember this. We know that you have to wait, I believe it's 3 months, to find out the sex of a baby, and really before it becomes clear. So what's historically taken place is that parents with intersex children were asked to choose the child's sex or sex at birth. So do you want a boy or girl, basically? I can't imagine, because the problem was the parent had a 50-50 chance, not great odds, of making the correct choice of what that child's sex was and how they would identify. Increasingly today, we're seeing that the decision is being delayed until the child actually reaches puberty. And a far more accurate determination of the sex can be made, and that child is asked, what sex they identify with. It's great. We've really come an incredible long way with this in being able to wait. and not have a parent have to make that choice when they really could be wrong. So cross-dressers are people who generally wear the clothing that are associated with the opposite gender. So just a brief note, people choose to cross-dress because they find it emotionally fulfilling or sexual ways. So transvestite is outdated. That was the term that was used for a very long time and is generally considered offensive. So do not use that word. Again, cross-dresser is the word and terminology we use today. So just to point out, cross-dressers may not be transgender. In fact, GLAAD has a great, if you're wanting more terminology, great media guide on terminology that goes even more in depth than what we have. And they point out that it's typically straight men who find enjoyment wearing women's clothing. That is a generalization, but that is typically what we see with cross-dressing. Transsexual is a term for people who live in a gender different from the one assigned at birth, who may want to seek intervention, whether it be through hormones and or sexual reassignment surgery. You're hearing transsexual used less and less, and transgender really become this umbrella term. So you don't always hear that. Sometimes you'll also hear just a shortened version of transsexual and transgender as trans. I also want to point out, and something that's really important for us as healthcare providers, my degree, as Abby pointed out, is from a school of public health, so I'm always thinking about prevention and how it's important in screenings. And something to consider is when someone, an individual, has had sexual reassignment surgery, they may still have certain parts, anatomy, that you wouldn't expect. So you may see someone who has made a transition from a female to a male, and they look like a male for all purposes, but that they still have ovaries or they still have a uterus, which means that they are susceptible or could get uterine or ovarian cancer. So knowing that and knowing that you may need to be screening for that is important. Same with a male transitioning to a female, might still have their prostate. And it's important, again, prostate cancer, very important to screen for. So it's really important as healthcare providers, and when we're going to talk about this, we have the trust of the individuals we serve, so they feel comfortable to talk to us, let us know, so we can be able to provide the absolute best and most holistic healthcare we can to ensure that everyone is getting the screenings that they should be getting and the healthcare they should be getting. I want to focus a little more on transgender and transsexualism in adults, and especially, and Sarah pointed this out, our LGBT individuals really have, and I'm going to talk about this, some disparities when it comes to healthcare. And it's important for us to address those, understand those, really, so we can help individuals overcome those barriers and serve them in the best way we can. So individuals, as I mentioned before, dressed like the opposite sex, can feel alone and have depression or anxiety. Depression and anxiety, there's lots of studies that show this, can be directly related to other kinds of physical ailments. I talked about it before, I'll continue to talk about it. Holistic health is really important. To think about individuals' psychosocial well-being, which includes depression and anxiety, are very important. So an individual wants to live as a person of the opposite sex, and I think we can see why this could cause depression or anxiety. If you feel you can't truly express who you are as a person. I think if we just take a minute to imagine what that was like, to wake up every morning and be fearful to be the person who you are, I think you could understand why an individual would have an increased risk of depression or anxiety. I currently live in North Carolina. As you may have heard of our bill we have that is concerning, but it's regarding bathroom use in transgender individuals. Very upsetting, and individuals, as all this has come to light, people have come forward, transgender individuals, to talk about the anxiety they feel just doing something as normal and everyday that all of us probably take for granted, but using a public restroom. So I think when we think about that and we put ourselves in other shoes to understand some of the issues they face, we can really understand why, again, transgender individuals may have a higher incidence of depression or anxiety. Some people have even been wished to be rid of their own genitals. And I just want to point out, it's transgender and transsexualism is not the same as homosexuality. A little interesting fact, Native Americans actually consider transgender and transsexuals to be individuals with two spirits. Kind of a nice way to think about that and how Native Americans look at that. Just really important that we make sure that all individuals feel welcome as part of our community. Continuing on with terminology, coming out, disclosing one's gender identity or sexual orientation to someone. I really want to be clear on this, and some people just don't realize this, but coming out is a lifelong process for many people, and people choose to do this so at different times in their lives. Older adults may choose to come out only to close family, but hide their sexuality from healthcare providers for fear of being treated poorly. An individual might actually go back into the closet. We've heard of this happening, unfortunately, when they're going into long-term care, whether it be assisted living, independent living, congregate kind of care living, or skilled nursing centers, because they're afraid of how they'll be treated. Homophobia refers to hatred or fear of individuals who are lesbian, gay, or bisexual. Internalized homophobia refers to people who identify as LGBT but hate themselves for feeling these desires. And minority stress is a chronic stress related to stigmatization and actual experience of discrimination and violence. And I said it before, but there has been a ton of studies that show stress can really impact you physically. We know this, and so it's really important that we are addressing anything that can cause stress, induce anxiety, and depression. I also just have to say, you know, we deal with this anyway when we're talking and thinking about older adults who have sometimes a higher incidence of depression and anxiety, especially when they're going through having to transition possibly from a home they've lived in to long-term care. So it's really important as providers that we're not just looking at physical health, especially in older adults, that we're thinking about screenings like depression screenings. A lot of times that gets left off, and I think it's one of the most important things when we're caring for older adults is that we're screening for depression. I also just want to point out, coming out, it's really important that you work with staff and that they understand they should not out someone. What you might think, believe, it's really just inappropriate. Same with other residents. If you are a long-term care provider, it is really important to make sure you do not have one resident outing another resident. Really important to work with staff and other residents on that. Continuing on with terminology, families of choice are a circle of friends who are likely to be the family for LGBT elders. Very important to LGBT seniors who may be rejected, or any LGBT individual, by their families of origin. So think through, and we're going to talk about this a little later on, but start thinking about documents you have, intake forms, whatever, and how you ask about people's gender, sex, family, of choice, next of kin, and really think, you know, are these as person-centered as they can be? Are these LGBT-friendly documents? Because those are really easy minor changes you can go back to your office, your center, your community, and make, you know, this week, next week. LGBT residents should never be denied visitation from their partners or families of choice. I can't begin to stress this enough. It always breaks my heart. You will occasionally see a terrible story where someone was denied access to their loved one because a healthcare provider denied them access. We've heard about these. I will let you know there have been lawsuits, and the healthcare provider typically does not win in that case. So not only thinking just from a person-centered approach, where of course if you were sick and wanted your loved one around, how terrible that would be to have them kept away from you, but also from a risk and litigation standpoint. It is never okay to keep people away from their loved ones. So very important that you know who their family of choice is and allow access to residents, patients, whatever, to their loved ones. Again, never okay to deny visitation from partners or families of choice. I want to talk about history, LGBT history in the U.S., because I think it's always really fascinating, how far we've come in a short time, but also surprising to see how much more we have to do, really. So the gay liberation movement didn't start in this country until 1960. So you think about like Stonewall. And many individuals were in the closet, some still are today, in fear of what would happen to them, and after the liberation movement. Before the gay liberation movement, and even after, individuals were very scared, and there was a risk if you were outed that you would be put in a mental institution, as shocking and terrible that is, without consent. We've come a long way. Homosexuality was not removed from the psychiatric community list of mental illness, so the DSM, until 1973. And it was even long ago, this wasn't too long ago actually, that it was common to publish names of people who were caught or thought to be LGBT where they worked, and forcing them to lose their jobs. So, again, we've come a long way. I think we still have a long way to go. But it's just really important that we realize some of the things that LGBT elders especially have gone through. So a lot of those of us that serve older adults have to understand that our LGBT elders have gone through this. They realized what this was with the gay liberation movement, whether they participated or not. They have had, a difficult history, and minority stress could definitely be an issue. I want to talk about laws impacting our LGBT individuals. So in June 2015, the Supreme Court ruled that same-sex couples have the right to be married nationwide. I'll talk a little more about that. This is just an overview, and we'll dive a little deeper into some of this. Up until 1975, the federal government had a hiring ban. The Supreme Court ruled in 2003 that sodomy laws used to arrest individuals were unconstitutional. In 2011, Don't Ask, Don't Tell laws were repealed for the military, and I just heard this morning that they are going to allow transgender individuals to openly serve in the military, which is wonderful news, and we're coming, as I said, we continue to take great strides. I don't know much else about that. I believe they're working on how to roll that out, but great news this morning. The Boy Scouts approved allowing openly gay scouts in 2013, but still bans gay scout leaders. I believe that is still current. I checked this when I last presented a month or two ago about the Boy Scouts. So I want to briefly talk about DOMA, the Defense of Marriage Act. And this was a really big deal because this obviously impacted finances, which we're going to talk about for our older adults. So DOMA was signed into law in 1996. It was a law that barred the federal government from recognizing same-sex marriages legalized by states. So what it did and how it impacts individuals was it prevented access to federal benefits for same-sex couples whose states recognize their marriage. So this impacted things like Medicare, veterans benefits, things we might take for granted, but really impact people and their access to long-term care, health care, being able to financially survive. So very impactful. In 2013, the Supreme Court ruled Section 3 of DOMA unconstitutional, which Section 3 was the part that prevented the federal government from recognizing any marriages between gay and lesbian couples for the purpose of federal laws or programs. So that's where it started to become more equal in regards to Medicare and other programs, federal programs. The other part of DOMA that still remains significant, or did, was that individual states did not have to legally acknowledge marriage of gay and lesbian couples, which we're going to talk about, as I mentioned. June 2016, 2015 was when the Supreme Court ruled that all states must allow same-sex couples to marry. So this means, as I mentioned before, what a lot of individuals didn't have access to, that all married couples have the following federal protections: Social Security, so death benefits, veterans benefits, health insurance, and retirement savings. I'm also going to talk about some data because I think the data is really important, and Sarah shared some of this too before, but it's really important to understand how our LGBT elders are impacted in regards to health care. So UCLA Williams Institute on Sexual Orientation and Law estimates that there's about 4% of American adults that identify themselves as lesbian, gay, or bisexual. And I will just point out, a lot of research in this area a lot of times focuses on lesbian, gay, and bisexual, and transgender individuals get left out. So when you don't hear me say that, it's just some of the research, but I think we're coming, again, a long way, and we are seeing more research and facts to support transgender individuals. It is estimated that there are 1.5 million LGBT Americans today, and then by 2030, there will be 3 million LGBT elders. So some characteristics that are really going to impact us as healthcare providers, but when LGBT seniors are less likely to be connected to biological families. You know, some of us might think, you know, that's not a big deal, but who's advocating, especially for seniors? You know, we talk about it a lot, that, you know, that daughter, that son that's in our center or community or coming with an older adult to a doctor's appointment is really their advocate. So if they're disconnected from a biological family, that could be an issue. As a second point, less likely to have children, 4 times less likely. You know, again, a lot of times it's the kids that are the biggest advocates. More likely to live alone. We know, and there's been research that shows, especially older adults that live alone are more likely to have anxiety issues, depression, and just be socially isolated. And less likely to reach out to mainstream services, which we're going to talk a little bit more about. So when dependent on health care, home care, or long-term care, LGBT elders may be treated as if they're heterosexual, have had a history of discrimination, as I talked about minority stress, have been separated from life partners, as we've talked about before, which can be incredibly traumatizing, and be forced to hide their sexual identity. We've heard stories of people moving in to communities or centers, and no fault to the center or community, but the individual felt scared and put away pictures. And we do a lot of work to make sure people feel at home when they move into our communities and centers, and we want them to show pictures of their loved ones in their room so they feel at home, and their room or their apartment really can be their home. And I'm sure you all have pictures of your family around, and we all want to feel that way. It makes us feel at home and safe and really connected to our environment. A little bit more data about LGBT adults less likely to delay or not seek medical care. Again, I mentioned before, I'm got my graduate degree, received it in a school of public health, and medical care is important. I can't stress enough preventative care, but really important when you look here, heterosexual adults versus lesbian, gay, bisexual versus transgender are even a higher, less likely to get care. So 75% of LGBT elders said they were not completely open about their sexual orientation to healthcare workers. And we know, when we're talking holistically, that we do need to talk about our sexual health. It's important. It can impact overall health, and we want to make sure people feel comfortable. LGBT individuals are only 20% as likely as their heterosexual counterparts to access services like senior centers and meal programs. And we know from research, senior centers and meal programs are vital. Meal programs for ensuring older adults are getting proper nutrition, and our senior centers for ensuring adults are getting that psychosocial interaction, which also goes for meal centers that have shown they really improve social interaction for older adults. Surveys show that older gay men or lesbians would not be welcome at 46% of local senior centers if their sexual orientation were known. I just want to give you a minute to think about that. Almost 50% in this research, which is disheartening. And as healthcare providers, I feel like we can make that change. We can ensure and work towards making sure that everybody feels welcome at the services we provide, and is able to come, that we provide a welcoming environment. That's what we're here for in health services. I know you all got in this field to help people. That's why we're all here, and we need to help everyone and make sure that everyone has access to good care. More than 1 in 10, about 13% of LGBT older adults report being denied health care or provided inferior care because they're LGBT. Again, I just want to say, you know, we're here to provide care to everyone, and not just care, good quality care to everyone. Everyone deserves that. Health care is a right, not a privilege. And that's our job as healthcare providers. And I know you all out there have big hearts because you're in healthcare. It is a hard job, and I know you want to help people. So that's what we're here to do, and I think we can really lead that as healthcare providers. I also want to talk about some of the top 10, we're in healthcare, medical issues that gay and lesbian individuals face. So issues for lesbians, an increased risk factors for breast cancer, but less likely to get screening. I've talked about screening a lot. As I said before, screening, preventive treatment is really important. Same with depression and anxiety. Chronic stress, as I've mentioned, from discrimination and loss of emotional support can lead to depression and anxiety. Heart health, which can tie in to depression and anxiety. Heart disease is the leading cause of death for women. And smoking and obesity are the biggest risk factors, which can also be risk factors that lesbians may more likely be affected by, which I'll talk about in my next slide. Gynecological cancers. Lesbians are at a higher risk for certain type of gynecologic cancers. Fitness. Research shows that lesbians are more likely to be overweight or obese. I mentioned that in regards to heart health. Tobacco, again, related to heart health. And research has shown that lesbians are more likely to use tobacco more often and consume alcohol, be heavy drinkers or binge drink. Again, this could also be related to depression and anxiety. Same with substance abuse. Intimate partner violence. Lesbians are less likely to be asked about prevalence of violence, and that should just be standard. We shouldn't figure that we don't need to ask about partner violence. It's really important to ask about that. Sexual health. Lesbians can get the same now called STIs, as heterosexual women. Top 10 medical issues for gay men. Coming out to your healthcare provider, and I think that goes for all LGBT individuals, and feeling comfortable to talk openly with healthcare providers. HIV, AIDS, and safe sex. I am going to say we hear a lot of stories occasionally about older adults. Something we need to think about is a lot of the older adults that are in our communities or centers, or you may be seeing in your practices or hospitals, did not have sexual education like we've had. That was later on. Some may have, and I know that sounds silly when I've said that to people. They kind of look at me funny, but it's true. There have been areas where we've had outbreaks of STIs in older adults or older adult CCRCs or communities. And a lot of it is just people haven't really been taught about this and don't think about it with older adults. So safe sex talks it's never too late, and it's okay to talk about that. Hepatitis immunizations and screening are an issue. Fitness, body image issues. Obesity can be an issue with gay men being a factor. Substance and alcohol abuse, as I mentioned before, also tied into depression and anxiety on this next slide, affects gay men at a higher rate than the general population. Again, STIs tend to be at a higher rate in gay men. Prostate, testicular, and colon cancer, access to screening may be harder due to lack of cultural sensitivity. So it's really important we make sure in our practices that we are culturally sensitive, and again, people are getting those screenings that they need. Tobacco, gay men tend to have a higher tobacco use. Again, it's not on here, but that does tie into heart health. And HPV, human papilloma virus, which can cause anal and genital warts and can lead to increased rates of anal cancer. So it's just important to kind of understand these issues that lesbian and gay men might face, so we're aware that we're screening and really looking for these, again, so we can make sure that everyone is receiving quality care. I want to talk about stereotypes. I think a big part of this presentation is education on terminology, but also talking about stereotypes and really breaking those down. So stereotypes are typically oversimplified and inaccurate ways of looking at groups of people who are different than ourselves. When we let these stereotypes control the way we see a person, we end up really not seeing a person for who they are and missing out on getting to know an individual. Stereotypes are so far from being person-centered that and I mentioned in healthcare we need to be person-centered, so we need to step away from those stereotypes. All staff in healthcare really need to be expected to treat all residents, patients with respect while working. I want to just take a minute. I want you all to think about a time that you've been treated differently or felt you were treated differently because of a stereotype. I know it's happened. I've never met anyone in any of these presentations that hasn't been treated differently or bullied. And I want to take just a minute for you to think about that and how it made you feel. It's hard to think about. We can all relate to this, whether it's a stereotype about where you're from, your ethnicity, your race, sexual orientation, your religion. You know, they're hurtful. There's a long history of stereotypes. I think we've made great strides with stereotypes regarding our the LGBT population, but I think we still have a long way to go. So I just ask you and to do this with your staff. You know, think about a time when you were hurt and how you feel. I think when we put ourselves in other people's shoes, we become more compassionate, and I think that's a really important tool to use when we're training staff. So identifying stereotypes. You know, we tend to treat them, individuals, with less respect for their individuality when we use stereotypes. And more often than not, I think we all can agree, stereotypes are rooted in untruth, you know, and not really about the person at all, and a lot of misinformation. I try to be a little Pollyanna in this and just hope that stereotypes are miseducation and that we can hopefully train and educate individuals to get rid of stereotypes. So stereotypes really tend to focus on our differences and ignore our common characteristics that make us all human. At the end of the day, we all look the same under our skin. There is a great little commercial that shows people, and they look just like little skeletons behind a screen. And it's amazing how much more similar we are to each other than we truly are different. Although everyone is different, but under it all, we look the same. I want to talk about LGBT challenges to aging successfully. And I know you might not be working with older adults, you might be working with younger adults, but in regards to aging, LGBT challenges, as I mentioned before, there's a stigma, and it's in the past and everything they had to go through, and we carry that with us, like minority stress, as I talked about. There's also present stress. You know, I can't help but think of the Orlando shooting recently, and that fear that you may be hurt because of who you are. Reliance on families of choice who lack social and legal recognition. I mentioned this, we've come a long way in regards to legal recognition and acknowledging marriage equality with the Supreme Court ruling last year. Also, unequal treatment under laws and programs for older adults. Again, we've made great strides with a lot of the programs, that's federal programs. Some state programs still have a ways to go in regards to being more equal. We also need to remember, as healthcare providers for a resident, a patient, whomever, we are that resident and patient's advocate. We are not the family's advocate. We are there to advocate for that resident. So it's just something to really remember. Other challenges, Medicaid regulations only protect homes of married spouses. This was a big issue. Again, tides are changing as the Supreme Court ruled in favor of marriage equality. But that was only a year ago. June 26th of this year was just 1 year. So we still have a ways to go. There may be individuals that, you know, don't get married, but still we need to think about things like this because this impacts economic, financial well-being of our older adults, right? So you need to make sure your staff understand anything about local or state programs that have been developed to assist in the LGBT community. At the end of the slide presentation, which you have access to, we've included a lot of wonderful resources that are out there to help you support LGBT individuals. Tax laws and 401k plans, again, discriminate against same-sex partners. We've come a long way with, not a long way, but within a year with the Supreme Court ruling for same-sex or marriage equality. But still, we have a ways to go. As I mentioned before, there's been issues with hospital visitation rights denied, and many LGBT elders experience social isolation and also ageism within the LGBT community itself. Very interesting when we've heard stories of this with older and younger LGBT adults. And something just to keep in mind when you have younger LGBT individuals working with older, that terminology, as we mentioned before, use of the term queer may be completely acceptable to a younger individual, but not to an older one. So it's really important to explain to our younger staff that things were very different for our older adults as they were growing up as an LGBT individual, and that they just kind of need to understand that, and things might not be the same. So I also want to talk about what caregivers can do for residents or patients or whoever you're caring for and how you refer to them. So cultural competence is extremely important. And cultural competence just refers to the ability of care providers to interact with members of different cultural groups. It involves an acceptance and respect for differences, an understanding of community norms, vulnerabilities, and practices. This goes for everybody, not just our LGBT residents and individuals, but it's really important that as healthcare providers, we are culturally competent. It's also important to draw a line in the sand and say we expect all staff to be culturally competent in a manner so they can support all residents regardless of race, religion, ethnicity, or LGBT. Caregivers are not employed to judge a resident or patient. They're there to be cared for. They're employed to meet the needs of the individual in the most person-centered way possible. Cultural competence really should be a goal. And what matters is that you respect differences as you would and expect from others, accept them and respect everybody. We say it a lot, but really cultural competence and respecting others is this essence of person-centered caring, and it's vitally important to healthcare. Getting to know your resident and patient through resident history is really important, so you know what's meaningful to them, and you're able to form a meaningful relationship that has trust and that they feel comfortable going to you. We are here to serve individuals and make sure, again, they receive the best health care they can. Culturally competent services are important, and it's important to communicate the community services to LGBT elders. I was just reading something, and an LGBT elder was talking about something they do when they go somewhere, healthcare, that they look at the reading material and kind of the posters up on the wall to see if it's, you know, LGBT friendly, and that makes them feel more comfortable. You really want to make sure you communicate the message of sincerity and caring to your LGBT elders, and create appropriate and acceptable services for LGBT residents or patients. Do you have support groups for LGBT residents or caregivers? You also really want to make sure, do we list all of these items on the slide? How are our intake forms? How are our history forms in our community or practice? Do we communicate that we serve all people? You know, what are your posters like? Are they all, you know, heterosexual individuals? You know, make sure that things are culturally competent and inclusive. Next is affordability, and I mentioned, and we're still at this place because we're only a year out from the Supreme Court ruling, and there's been a lot of states that have really tried to challenge that ruling, that we make sure that services are affordable. As I mentioned, it's been hard to get access for some individuals due to limited access to only married couples in regards to services, Medicaid, 401k, plans, survivor benefits, things like that. So things that you can do, think of using the rainbow flag, which is typically seen as a welcoming sign to LGBT individuals. Saying things like, we welcome all races, religions, and sexual orientations. And I just want to say too, when we're thinking about this and you're thinking about how can I make my services more culturally sensitive and competent, keep in mind at the end of the day, sexuality is a small role of who a person is. We share a lot more in common, as I mentioned before, but just something nice to keep in mind. So education and training. Ongoing sensitivity training that includes sexual orientation really can help to decrease instances of discrimination in staff, among residents, which is really important. Not just important, too, from making sure people feel comfortable, because that is absolutely important, but also from a risk management standpoint. It's really important to think about that. Posting of the community's non-discrimination policy for public view can help people feel more comfortable and more welcome. It can also draw that line in the sand where you show staff and everyone coming in that this is what you focus on, that this is important for non-discrimination, and this is what you stand behind. I also want to talk about sexuality and aging, and just take a minute, because this has become a really big topic over the past few years, and we're seeing more and more stories about this. And this is really important to talk with staff, I think especially younger staff. Sex is a normal part of aging. And normal is not in that slide, but absolutely 100% should be. It's normal for seniors to remain sexually active regardless of age. I talked about sexual health and sexual education, and that is really important. Again, people might not realize because they weren't taught this back when they were in school, but it is really important that we think about this. Elder sexual needs in assisted living communities, nursing, for those of you in the hospital or other healthcare settings, need to be treated with respect and privacy. I can't stress this enough, and we are hearing this on the Hill in DC. There are stories coming out about young individuals and staff members using Snapchat and Twitter and Instagram and other social media in taking inappropriate pictures or discussing things. And not all are focused on sex. Some have been. And it's disturbing to see. And it's important that we talk with our staff and make sure they're trained to understand that an individual's sexual needs, desires, activities are to be treated with respect, dignity, and privacy. Just because an individual moves into an assisted living, an independent living, or a skilled nursing does not mean they lose their autonomy. It is really important. It should be discussed with staff. Staff should be trained on this. Staff should not be giggling and talking about to residents if they are in their private lives. People should be given space, and that is really important. It's also important on the side of screening to be thinking about, this is a screening question, asking if individuals are sexually active. This impacts things like sexually transmitted infections. So just something to think about, and I think a lot of times we pass on. We think, you know, older adults are not having sex. That's not the case. There have also been, and I will throw this out, I am not an expert in this area, but I've talked to a lot of individuals who are doing things like this and thinking through when an individual moves in, if you're in assisted living or skilled nursing, about talking about this and signing some kind of agreement. There has been some risk and liability issues of older adults having sex regarding mental cognition, if they have dementia or not. There have been stories about this. So it's just really important also to think from a risk and liability standpoint also. I mentioned this, but the right to privacy, every resident, as we all have a right to privacy. If they are in your assisted living, your skilled nursing, your independent living, that is their home and they deserve that privacy. As I mentioned before, it is never acceptable to speak or gossip about consensual sexual activities of another resident with other staff, other residents, anyone outside of the community. That is a really good point to train staff on and something that all staff needs to understand. So going through some questions, do aging LGBT individuals have unique needs? Not really. What all residents need to feel is acknowledged, included, respected, and understood. I think that goes for everybody in general where we get our health care. Person-centered care focuses on meeting the residents' needs through the development of meaningful relationships where people can feel safe. You should feel, your residents, your patients should have a trusted relationship with you so they can talk about their healthcare needs, their psychosocial needs, and really make sure, again, they're getting person-centered care. Staff should know residents. They should know their history, their needs, their preferences, expectations, things like that, what they prefer to be called. Approach like this really minimizes bias towards residents based on their sexual identity, cultures, or belief systems. Also, I mentioned it before, but we truly have more in common than we do than not. Everyone does have individual characteristics and beliefs. That's what makes us different. That's what makes us such a great place, is that we're all different and we bring something unique to the table. But don't lose sight, if you are someone straight, that you will bring a straight bias to the table, and you may not view issues in the same light as LGBT residents or patients. And so you just need to remember that. You also want to be person-centered. You don't want to assume that every LGBT resident you care for is the same just because he or she is LGBT. Everybody's unique. I mean, that goes for everyone. Just because someone is, you know, from a certain area and looks the same, they might not like the same things as another person. Just really important to remember we're all unique. Ways to achieve person-centered care, and person-centered care is picking up so much. We've seen such a change in the last few decades, in long-term care especially, but also just in healthcare in general. You really want to encourage a resident's personal development. You want to make sure that you're maximizing dignity, autonomy, socialization, which is vitally important to older adults and their health. Again, I've said it before, but there are studies linking socialization to other healthcare outcomes, specifically in older adults, and socialization younger as we age, how it impacts us as older adults. It has been linked to dementia. Support lifestyle, support people in what they want to do, in their activities, and their hobbies. Promoting family and community involvement, and again, that includes families of choice. You want them to be involved. If you have family and resident counsel, you want them there. Ask about who their family of choice is and who they want involved. And again, I say this and I stress it. You want good, positive relationships with staff, the residents and community. It's what makes your place great, when you have good relationships and people can trust you. So how do we provide care to LGBT individuals? If you're a nursing home or assisted living or even other healthcare provider and you are thinking about intake forms, think about admissions. I've mentioned this before, but should you ask information about families of choice and origin, so you capture who's important to that resident. Interviews should always be one-on-one conversations, so they create a comfortable atmosphere for the resident to share information. You should never be doing these out loud. And I will say, if you are doing an interview and you are getting to maybe sensitive questions and someone doesn't want to answer those, don't push. Just move on. And you can always go back to them, but if that individual doesn't, it may be a while before they answer a question they're not comfortable answering, or it may be never. And that has to be okay. You have to be able to move on. Don't push. You want an individual to trust you. Marketing materials. Always look for new materials that illustrate diversity and the many faces of aging and individuals. I have to mention, stock photos have become incredible over the years. They're so diverse, it's really impressive to see how far we've come with these stock photos that a lot of us utilize in marketing materials. I also need to point out, if you're unsure of how to refer to a resident, whether it be Mr. or Mrs., simply ask them for what they prefer and get the gender pronouns correct. You can add things on your admissions like partner instead of spouse. You could do spouse/partner. And adding things in, like I mentioned before, families of choice. You can also, on forms, ask, instead of things like, are you married, you can ask for who do you live with, or who's important in your life. You can also, what's really important and how you can provide care is to understand and respect diversity, especially within aging populations. Let the resident guide you, excuse me, and recognize that minority stress is a factor. You want to determine the level of self-acceptance, support, and social network as part of the admissions process. Avoid assumptions or judgment. Don't assume someone is a lesbian, gay, transgender, or bisexual. Never assume. And never make judgments. An individual who's transgender may be uncomfortable with bathing or dressing assistants, so you need to be culturally sensitive about that. You want to reduce stress and make sure that people feel loved and welcome. You also want to make sure, as I've said before, you acknowledge and respect family of choice. And I will say this over and over. If you make a mistake, apologize. There's research that actually shows, not in this case, but physicians that have made a medical error during surgery and apologize have less of a chance of being sued. I'm not saying that because this could be a litigation issue, but I think it shows the strength of apology and how important apologizing is. We are human, we make errors, and it's going to happen. But what's really important is that you apologize and try to do better. Residents have rights in long-term care. Specifically, a lot of states do have residents' rights listed out. Residents have the right to choose a physician and be able to choose an LGBT-friendly doctor. I really think that's part of what we do, is helping our residents find physicians, other clinicians that they're comfortable with. As if you are long-term care and you are bringing in volunteers or other providers, you can work with them on admissions and how they're asking, and help them to be more culturally sensitive if they're not here. As Abby mentioned, this is going to be taped, so you can have them view this. It's really our job to make sure everyone who is coming in contact with our residents is really culturally sensitive. We want to make sure of that and really work towards that. Everybody, as I've mentioned before, has the right to privacy, dignity, and respect. We should protect residents from hostility. I get a lot of questions about what happens with resident-to-resident hostility. You need to step in. You know, it can be really difficult, as I mentioned before, especially as we face a higher and higher prevalence of people with dementia, because of course that filter is gone a lot of times when you have dementia. People say things they wouldn't normally say, but it's important to work with residents and families, because you don't want resident-on-resident bullying or resident on staff or staff on resident bullying. So it's really important to make sure you have a situation where there's trust and respect for everybody. Also, the right to one's own possession. So allowing transgender elders to dress as the gender of their choice. Staff cannot take away clothing of an individual. The same would go for someone who is cross-dressing. That is their property. They have the rights to their property. And it's important that all staff understand and also realize that. Residents also have the right to visitors of their choice. We talked about that on families of choice, so you know who's there. They have the right to be free from abuse. If there is family in their lives that have been abusive or hurtful to them, it's important to know and understand that. There have been stories about biological families coming into older adults' lives and trying to take out families of choice or partners or loved ones, and that's never acceptable. So it's really important to make sure that you understand that of that individual. They feel comfortable to share who their families of choice are and who they want as visitors. Also, the right to voice grievances without restraint. If someone is feeling something has happened, our residents and patients should have the right to voice a grievance without fear of being kicked out of the practice or the community or the center. We all should be able to voice our concerns or grievances. So I'm going to go through some frequently asked questions, and some of you may be thinking, you know, these are very easy, but we still get these questions. So we've kept these in. And we'll just go through them. And again, we'll have some more question and answer at the end of this. But what difference will it make in the care I provide, whether the resident is hetero or homosexual? So as a caregiver, you want to demonstrate your level of understanding to anyone, any special needs. And the bottom line is you should provide the same excellent quality of care as you would to any resident, to our LGBT residents. It's important to love and accept families of choice and to recognize their families of choice as partners, wives, and husbands. Again, we just strive to provide quality care, regardless of who that resident or patient is. That should just be your focus. Provide high-quality, person-centered care. A question we've still received are, aren't homosexuals primarily responsible for the spread of HIV/AIDS? A simple no. It is not true. It's inaccurate, and unfortunately, I think some people still think that today, but no. It's important that we practice standard precautions for all residents. We need to be following OSHA, any state laws you may have mandated, but you should practice and staff should all practice precautions for everybody. Isn't it difficult to talk with staff about caring for lesbian and gay residents without getting into a debate about whether homosexuality is right or wrong? No. It's not necessary to get into that debate when you're speaking about this. Our goal is to train staff and convey that staff are to provide quality care to all residents, and sexual orientation should never change this. They are paid to provide care to everybody, fair, good, quality care. And that is, at the end of the day, the most important in person-centered care. So what happens if you do or say something insensitive? I said it before, apologize and let the resident know how much he or she means to you and how you can make it right. That's just what's important, is apologizing and making it right for next time. Do your best not to say something insensitive, but again, we're humans, we make mistakes and we make errors. What's important is what we do after we make an error, is how we write it. So how can you get started? Assume or presume that you have LGBT residents, patients, consumers. Don't assume you can identify LGBT individuals by appearances, experiences, or external characteristics. Remember that a resident's sexual orientation and gender identity are only two aspects of a person's overall identity and life experiences. Do ask your clients about sexual orientation and gender identities in a safe, confidential manner. Again, I remind you, don't ever force someone to answer. If he or she is uncomfortable, move on to your next question. Don't assume that treating everyone the same is effective or will make an LGBT older adult or adult feel safe or welcome, because most caregivers will come at this from a heterosexual view. So it's just important to have cultural sensitivity. It helps us with everything and really to provide that person-centered care. In 2009, Secretary Sebelius announced an LGBT Resource Center. There is great resources on there. Again, I'm going to talk about some additional resources at the end. You have access to these slides. I encourage you to get them. There's other wonderful resources out there. There's great training, a webinar series that was done by the National Resource Center on LGBT Aging, really short videos I would encourage you to utilize and also utilize with staff. The Department of Housing and Urban Development, HUD, issued LGBT non-discrimination regulations in publicly funded housing with explicit language redefining family. So LGBT families do not face impediments when qualifying for HUD programs. If you are a HUD provider, you should know about these rules. If you do not, I would highly encourage you to make sure you are following them. There's great additional resources. I believe, yes, there are links to these two resources at the end. They are great PDFs. I believe we also have some at the office that we might be able to send to PHCA. I can check. Our resources were low, so I would highly recommend you probably download the PDF of them. And also, as I mentioned, great training resources. I can't stress enough the training videos on this link here. They're great, really short videos with question answers and also a PDF guide that you can download to help you go through. SAGE has incredible resources, LGBT Aging Center, GLMA. GLAAD has great ones, and that's GLAAD, that's GLAAD.org. And then there's a link to the LGBT Health Center that Secretary Sebelius has started. In conclusion, no one fully understands everyone's cultural or personal characteristics. We just don't. And it's necessary really to learn and show respect for cultures and for those people with whom we interact. I can't stress enough, it's how we provide person-centered care. You really want to get to know someone. I can't imagine trying to provide person-centered care without knowing someone. And we get to know people by developing meaningful and trusting relationships with our residents and our patients and those that seek our services. And I said it before, but it's why we're in the field. I'm sure you're in healthcare to help people, and our goal is to make sure that everyone receives high quality care that's holistic and thinks about the whole individual, not just a certain aspect of them. So we really can deliver that health care. And that health care is really a right. Good health care is. So thank you all. I know we are going to turn it over for questions and answers, hopefully answers, but questions. On the slide, Dr. Levine's contact information is there, and my contact information is there. I always encourage people, I do travel a lot, to contact me via email. But I want to thank you for joining us today on this webinar. I know you all are busy, and it's just a great pleasure to present, so thank you.
Lindsay, thank you so much. That was great information. At this time, we'll open it up for the question and answer portion. You can use your question pane on the right-hand side to submit your questions. We have a few already, and we were just joined by Dr. Levine, so both Lindsay and Dr. Levine will be fielding the questions.
Good afternoon. This is Rachel Levine, and I'm very pleased to be here.
Thank you for joining us. So I will start. I'll read the question, and Dr. Levine, if you would like to field the first. The first question was, referring to the Q in LGBTQ, I thought it stood for questioning, as in questioning sexuality.
So often, actually, you're correct, that Q can represent questioning, and that would be individuals who might question their sexual orientation, as has been discussed, but also those who might question their gender identity. So Q really stands for queer, which I believe was discussed, but also it stands for questioning.
So the second question, can you please give an example of using gay as a noun? This questionnaire wanted to understand so she could avoid using it in the inappropriate.
Yeah, gay is really an adjective. It's really not a noun. So you wouldn't say that John is a gay. You might say John is gay, or that's a gay organization, or something like that. But it's an adjective, not a noun. The same actually is true for transgender. So I've heard in the media sometimes that someone would say that that an individual was a transgender, and that's actually incorrect. What we would usually say is that individual is a transgender person or a transgender individual, or you might say a transgender man or a transgender woman, but it's an adjective, not a noun.
Okay. This question is more related to assisted living. Lindsay, if you want to field it. If you don't cover in the presentation, in room placement in a semi-private room, how does the center choose the room assignment for a trans resident, etc.?
That's a great question. I think you ask the resident what they're comfortable with. I think, again, it goes back to talking with the resident. And then also their roommate, which is, I will say this too, that goes with any roommate situation. You want to make sure people get along and feel comfortable.
Great. Another question. In a state like Pennsylvania where we don't have LGBT inclusive non-discrimination laws, we can't ask questions about sexual orientation and gender identity, potentially open someone up to further discrimination and potentially deny services. How do we communicate to patients the reasons why we are collecting this data?
So that's a very good question. So first is that we are hoping that comprehensive non-discrimination will be passed by the legislature, and Governor Wolf and the administration are very firmly in support of that. But you're right, currently Pennsylvania as a state does not have that comprehensive non-discrimination that includes sexual orientation as well as gender identity and expression. In a clinical setting, though, often what I would do is when I started to ask personal questions in general, is that I would say, Mr. Jones or Mrs. Smith, we'd like to ask some more personal questions, and we ask everyone the same questions in order to get a more complete history about someone and to be able to provide them better care. And that's how, and then launch into lots of personal questions that you might. Probably the first one I wouldn't ask is, can you tell me your sexual orientation? You might want to ask, about their friends and their family and their hobbies, and start with sort of more neutral questions first. But as you get more personal, I might even say again, we ask everyone the same questions. Because to be honest with you, as has been noted, everybody has a sexual orientation, one way or the other, and with lots of variations, as you've heard, and everyone does have a gender identity. Now that might be cisgender, consistent with their birth sex. It might be transgender, and there are those who say that they are gender nonconforming or genderqueer. But those questions are all fair and valid, and really we should ask everyone those questions.
Great. We'll leave the question and answer portion open for a little bit longer as we field the questions as they come in, and we'll pick it back up in a minute or two as they come in. That was the last of our questions. Dr. Levine would like to close by saying a few words.
Good afternoon. Thank you so much for attending this webinar. I would like to thank the Pennsylvania Healthcare Association for hosting this webinar, and I would also like to thank Dr. Lindsay Schwartz for her excellent presentation. I do want to assure everyone that that LGBT issues, non-discrimination that includes sexual orientation as well as gender identity and expression, is a priority for the Wolf administration. We have a interdepartmental work group that is working on all aspects of these issues, and it does include the Department of Aging. As you have heard, LGBT seniors have experienced stigma and discrimination in the past, and we want to encourage everyone to create a safe and affirming space for all of your staff and all of your residents. Thank you for participating in this webinar.
Wonderful. Thank you to Dr. Schwartz, Sarah from Dr. Levine's office, and Dr. Levine for taking the time to educate and engage us in this discussion. PHCA and our members share a commitment to the highest level of care to ensure that our aging population and disabled residents live a healthy, safe life and age with the dignity and respect they deserve. To achieve that, we must understand each of our residents' unique and individual needs, and I know that if you were participating today, we share that priority, and we thank you for your engagement and commitment to quality care. Again, your certificates will be emailed before the end of the day today, and a recording of today's presentation will be available at phca.org. Please feel free to share. Thank you again to our speakers. This concludes today's webinar.